Hello, everyone. Welcome to the podcast. So today we have the privilege of speaking to Dr. Ron Daniels. Ron is the esteemed founder of Sepsis Trust UK, an organisation dedicated to raising awareness and improving the management of sepsis. The clue's in the title, of course. As we delve into the intricacies of this vital topic, I'd also like to take the opportunity to explore the significant role that community pharmacies play within the broader healthcare system in the UK. With 1.6 million people accessing community pharmacy services every day across the UK, their impact on public health, well-being, and perhaps spotting sepsis is far-reaching and profound. Community pharmacies serve as a crucial first point of contact for many individuals seeking medical advice and services. They offer a wide range of benefits, including convenient access to healthcare, especially in the underserved or rural areas where medical facilities may be scarce. And unlike uh, most GP services that require appointments, community pharmacies often do not, although that is in some cases changing as we morph. When I say we, I mean the community pharmacy sector morph into a more appointment-based system. And one of the standout advantages of community pharmacy is their ability to alleviate pressure on the NHS by managing conditions that do not require a GP's expertise or emergency care. And that was never that impact was never so profound as it was during the pandemic, where community pharmacists and their pharmacy teams were instrumental in delivering vaccinations, certain testing and advice, and ensuring that community pharmacy really in that time of need and difficult time were an outpost and a network that the government could make use of, really. So in our interview with Ron today, he's going to hopefully share his insights on the evolving landscape of sepsis in the UK, just how much the public knows about sepsis and what information is available to them, the challenges faced by the sector, and the innovative solutions that are shaping its future. So, Ron, lovely to see you. I'm speaking to you. Probably shouldn't date a podcast, but I'm speaking to you in the summertime. Are you having a nice summer before we dive into sepsis?
Well, that's very kind of you to ask. It's a busy summer. We've just moved house, Jonathan. But yeah, apart from that, it's as good as we could expect given the British weather.
Good stuff. Good stuff. So, Ron, I wondered if you, just before I ask you the first question, would you, I've done you a bit of a disservice. I haven't sort of given a bit about a bit of background about yourself. So would you mind sort of maybe taking a minute or two just to sort of describe your career? I was going to say your life journey, but no, let's not go that deep. Let's just go for your career journey and sort of describe some of the things that have happened to you on your career journey to lead to you speaking to me today.
I suppose, like many health professionals, many doctors, but also very unlike many, and that I really did almost fall into medicine. I remember selecting my A levels at school. I was much more interested in the sciences than in anything else, and I didn't really know what I wanted to do with that. And it was only really when I was entering my final year at school, my upper sixth, that I started to express an interest in medicine and to take an interest. And then hit medical school, really enjoyed medical school, as much for the social aspect as anything else, of course. And again, sort of churned out the other end, not really knowing what I wanted to do. But there've been a couple of real life experiences during my career in and around the West Midlands, exclusively in and around, sort of really as far north as Shrewsbury, as far south as Kidderminster, as adventurous as my NHS career has been. The first is that I was working in accident and emergency in Shrewsbury as an SHO, and I just observed that all of the anaesthetists, because intensive care was exclusively delivered by anaesthetists in those days, all of the anaesthetists who came down to A&E seemed happy. They were really interested to teach and to tell me what they were doing and why they were doing it. And I just thought, well, they must have a lot of career satisfaction. So I gave it a go. I went and started in intensive care, actually, because it was the first job I could get, and then went and did my anaesthetic training. And of course, never looked back. And for many years, I was an anaesthetist as well as an intensive care doctor, doing both. A few things happened, and I started to observe, and this was only my personal experience, that I wasn't finding anesthesia quite as challenging as I used to, perhaps because I was doing fairly straightforward cases in a district general hospital. And I'm someone who likes to be challenged. So I let go of anesthesia, and now I'm just an intensivist. And in terms of the reason I stepped into sepsis, this was an alignment of planets, really. In 2004, the International Surviving Sepsis Campaign, who are the academic guidelines group for sepsis worldwide, they released their first set of academic guidelines on how to recognize and manage sepsis and septic shock. And at the same time, a young man called Jem Abbott's his name. He was 37 when he died in intensive care, and he died in front of our eyes. There was nothing we could do to save him. And he left his wife, now widow Karen, and their children, Tom and Emily, who were 9 and 6 at the time. Of course, they've both now been through university. They've both got successful careers and relationships. And Karen's remarried too. So it sort of has a happy ending out of tragedy. But I remember thinking, Jem didn't need to die. And that could be my then wife being told that her husband wasn't coming home. And it could be my kids who were similar ages being told that daddy wasn't coming home. I just thought, this is unjust. There's no one championing this cause, and we have to do something about it. So to cut a very long sort of 20-year story short, the first thing I did was join the Surviving Sepsis campaign, fairly quickly became the chair of the UK steering committee for that organisation, and then began to reflect that we really needed to get this to the grassroots. We needed to stop it being about academia. We needed to empower junior health professionals and get the message out to the public, to the media, to our politicians. And that's how the UK Sepsis Trust was born.
Awesome. And you're obviously very good at media, because you've cleverly preempted my first question, which is what was the case that inspired you? And obviously it's that very profound story you tell there about Jem, tragic, of course. And I can totally understand, Ron, why you were inspired, especially to use your words there. He literally didn't need to die. On a lighter note, let's segue to a slightly more positive note. We've got something in common, actually, that I didn't know before I started speaking to you today. I've got two older brothers, and one of which, he's the successful one. He's actually an anaesthetist as well. So I know something of the world of anesthetics for third hand anyway. So and your career journey is very, very interesting. One of the things about intensivism, and I am very broad brushing here, and I'm coming from a pharmacy perspective, but one of the things I've discussed with folk that medics or pharmacists that are highly specialized is that, you when you're treating someone generally face to face, you're treating that person in front of you. And in your case, it's pretty profound. It's like often, I guess, life and death. Your decisions will have a pretty big impact. And sometimes I've had conversations in the past about this, and I've never really. I suppose we pharmacists advise on an individual basis and so on and so forth. But what I'm quite interested in with community pharmacy, particularly, is impact. And obviously, how we measure impact varies across the ecosystem, doesn't it? But I am very attracted to the fact that this literally millions, I think 1.6 million people access community pharmacy. So my point I'm making in a very labored way here is, I guess the question off the back of this is, what is your perception of community pharmacy? But the context to that is, how do you see that 1.6 million sort of almost passive footfall coming in and out of pharmacies on a daily basis. I mean, that must be of use or potential use to you and others in the Sepsis Trust who are, I think the juxtaposition of you being inspired by an individual critical, tragic case is quite interesting when you set that aside, speaking to me who perhaps makes hundreds, thousands of relatively low level interventions on a daily basis. I'm just interested to speak around that, if you would, Ron.
Yeah, absolutely, Johnny. I will talk to that. I just want to make sort of two brief points first. And firstly, I want to say that Karen, Jem's widow, is a friend of mine and a friend of the charity to this day. So, she's been on this journey with us. And secondly, to make the point that, intensive care, yes, there is a lot of decision making, a lot of very impactful decision making, but I really want to reinforce it is as a team. The health professional, the doctors work very closely with the nurses, the physios, doctors from multiple disciplines, and we deliver patient care as a team-based approach. So in terms of pharmacy, obviously I've got sort of a couple of perspectives of direct experience, and then some ideas really that arise from the opportunity of these very, very many visits to community pharmacy that we see every year across the UK. Obviously, I've used community pharmacy as a service user, and we have worked with some of the major pharmacy chains to deliver public awareness to their clients. And that's really the sort of the very basic level concept that we can employ to really harness this incredible footfall of people, that this is about public awareness. Getting sepsis right every day means that we need a public who are aware, who are empowered, they know when to access healthcare, they know how to access healthcare, as well as health professionals, of course, who are well trained, well aware of sepsis, operating in a resourced environment, and most importantly, operating in an organization that nurtures a culture of empowerment to treat cases of suspected sepsis rapidly. So those are the sort of very basic aspects. And of course, we've got multiple public health information resources, which we developed with Public Health England as was, and they are available to pharmacy colleagues in terms of posters and leaflets and anything else. And then we move into, the areas that really harness the skills and the training of a community pharmacist. And, increasingly we have to recognize that as people, in the UK, the devolved nations, as well as England, find it increasingly difficult to access ambulance services, access emergency departments, access general practitioners, community pharmacists are now very much the eyes and ears of the healthcare system. I suspect, and I don't know because I'm not a community pharmacist, that they're seeing people who are increasingly comorbid, presenting increasingly unwell with their acute illness, whereas these people might previously have found it a lot easier to get into other areas of the healthcare system. Mm-hmm. So in terms of being our eyes and ears, pharmacists are really well equipped to understand what constitutes the signs and symptoms of an infective illness, to then, if they believe that someone probably has a benign self-limiting viral illness, to offer them safety netting, to offer them some information around what to look for if they're getting worse. Perhaps similarly, if they're dispensing antibiotics to a patient, to also offer safety netting. And again, the charity has resources in that regard. But I'm well aware that the role of community pharmacists is expanding, and we're increasingly talking about the taking of vital signs observations within community pharmacy. We're increasingly talking about the integration of diagnostics within community pharmacies. And there will be some pharmacists listening who are less eager to extend their roles into that scope, and many who are incredibly eager to do so. And I think the NHS, as it stands, is not going to improve anytime soon, even under the new government within England, I suspect. And I think, therefore, community pharmacists are going to have a huge role to play. And it may well even be that in the not too distant future, the community pharmacists are empowered to if not diagnose sepsis, but actually to diagnose a strong suspicion of sepsis and to make recommendations around immediacy of access to healthcare.
There's so much within what you've just said. To go back to I will, and I'll come back, and then we can chat again. But to go back to the previous point, it was me. You made the point better than I could. But the example as you were speaking that came to mind is smoking cessation, and the potential impact that community pharmacists can have if they it's quite, many sort of clinically snobby people would say, oh, well, that's a bit boring. It's not very intellectually challenging to get someone to stop smoking or coach them and that kind of thing. But actually, the impact of that is absolutely massive potentially and life extending. And I was just, as you were speaking, I was just sort of, trying to interlock sepsis. How does that fit into that? And you said it's like eyes and ears. So that's really how I see community pharmacy. And the rate that, like, the core benefit is like reconnaissance, brief interventions, Ron, I bet if you were, as a medic, if you worked in community pharmacy, you would have a rich bed of information that you don't get. You've got, like, I assume in your role, you've got very reasonably short, infrequent consultations with people, particularly in the follow-up. And as a community pharmacist, we see people every month, every 2 months. It's a different clinical area, but if someone's feeling a bit down, they might be gaining or losing weight, or they might look a bit sad, or and all of the above. But I think you've hit the nail on the head there. But I suppose in that context, it's like, what, in your opinion, does the pharmacy team need to know? And you mentioned about extending roles. You're absolutely right. One thing that is true about community pharmacy, there are early adopters there in terms of extending scope and that kind of thing. But the team element of community pharmacy is often hard to find, and you mentioned it there in your high pressure sort of decision critical environment. You mentioned that you do that as a team, and I mean, I don't know whether it shocks you or not, but many community pharmacists work completely in isolation. They'll see acute cases off the street. They'll do their best to safety net and what have you, but often they don't have access to records either of any kind. So I'm all for extending the scope of community pharmacy, PLC, as it were, but it's really the how and the infrastructure that's quite interesting. And in relation to sepsis, it's like, what, in your opinion, or how far can we go? And what's, I suppose, maybe, is it like a gold, silver, bronze approach? Like, what is the bronze sort of set of stuff that every pharmacy team member needs to know, Ron?
Yeah, great question. I really like the sort of the bronze, silver, gold to describe. I suppose we're talking about, levels of resource and capacity as well as levels of aspiration towards an extended role, aren't we?
Absolutely, yeah,
I,
yeah.
I think, at the basic level, if you like, the bronze level, which is far from basic, this is around it's around pharmacists who recognize that someone is describing or exhibiting some of the symptoms and signs of infection. They're providing advice. As I said, they might be dispensing, and it's really either verbally or really, I don't know, should we say, even for bronze, in written form, to provide safety netting information. So, a verbal thing would be, look, I think you've got, for example, a benign self-limiting viral illness. Obviously, pharmacists wouldn't use that terminology to the patients, but you know what I mean. I think you're going to be fine. I think you can take some antipyretics, get some rest, stay hydrated, all of those things that you would normally be doing. But say, very critically, but if you start to feel very much worse, then go to 111 online or make an appointment to see your GP and just ask, could it be sepsis? And I think pharmacists are really well placed to reinforce that empowerment of members of the public and their clients. I think they could then go and say, look, if you're really, really unwell, go to sepsistrust.org. They've got a list of symptoms there. If you think something's very badly wrong, then you need to look at that symptoms list. And if you have one or more of those symptoms, you go straight to A&E. I think pharmacists are also well placed to tell people, if the client is the patient, to tell the client, talk about this to an advocate, because if you get worse, you might not be able to read stuff online. You might not be able to access the internet very easily. So tell
Interesting.
someone close to you to keep an eye on you, and where to look for this information as well. So if that's bronze level, then I think, with silver level, we've got to build in this written delivery of safety netting resources, whether it be cards, whether it be fridge magnets, whether it be leaflets, all of which are, of course, available. It's routine. It's identifying the cohorts of patients that they feel should receive that safety netting information. And that will include people with acute illness, the people I've already described, the people who are being dispensed antibiotics, and so forth. But it will probably also be people with chronic illness, so people with risk factors such as not desperately well-controlled diabetes, people who take more than minimum dose steroids for an chronic inflammatory condition. Obviously, these people are at increased risk of sepsis, and it might be worth thinking about providing them with safety netting information. And then we could bring in at silver a sort of a triage environment, and this will depend on resource and capacity, of course, but this is before we start talking about these greatly extended roles. There are telephone triage tools that are being used by call handlers in many out-of-hours services, many 111 services up and down the country, and there's no reason a community pharmacist could not use those tools to sort of try to ascertain whether that patient needs to be seen by their GP, needs to be seen in hospital. It's sort of formalizing the conversation. And then I think gold is going to appeal to those pharmacists who've already taken an extended role or aspects of it, or those pharmacists who want to do that, those pharmacists additionally who work in an environment where the resource and capacity is available, is to measure the vital signs. There's no reason a community pharmacist should be any less good than a nurse or a doctor at measuring vital signs and recording vital signs. And in many cases, they may well be better. And we've got nice approved resources that can use those vital signs to inform action, and that may well be an opportunity. I think as we look to the future, and I'm really sorry, Johnny, my answers are all very long, but I think it's because your questions are great. I think moving to the future, we are likely to see very, very an absolute surge in the amount of technology we have available to distinguish between bacterial infection, viral infection, non-infective causes of inflammation. And I think a lot of these diagnostics are going to be accessible outside laboratories. So I can see community pharmacists, community diagnostic hubs accessing these services, and really pharmacists playing a role not only in recognizing severe bacterial illness and signposting people to hospital, but also in sort of, antimicrobial stewardship, and sort of considering where if a GP hasn't had access to these diagnostics, hasn't had time to take the vital signs, that a pharmacist could actually say, well, hang on a minute, I see your script for coamoxiclav, but, everything's pointing to the fact that this doesn't need treatment with antibiotics. So maybe I'll pick up the phone to the GP and have a chat.
I don't apologize for long answers. That's absolutely fab. I mean, folk who listen to this podcast they don't. I'm convinced they don't come to listen to me. It's the people that I get on, so that's absolutely perfect. No, it's really interesting what you say. I mean, again, my mind was, as you were speaking, it was wandering. I quite like how I don't know whether it's how I shaped the question or whether that's your natural feeling. Anyway, you went down the route of describing lots of great stuff about our profession and the community pharmacy sector without before you got to the advanced roles. Now I am a prescriber. I've done some of that stuff, and it's great and it's interesting, and like you said, you like to be challenged. There are lots of people like me like that, but it's really interesting. In my career, I think I'm coming full circle, and I'm thinking like, look, I'm a pharmacist, right? Okay, well done me. I'm okay with the kudos that comes in a local community of being that sort of role and so on. But for me, it's about outcomes, right? And I think the community pharmacy network, with a little bit of thinking and a little bit of future proofing, could use that huge footfall that comes in and out the door to deliver massive impact. And what you've described is one example. I hadn't thought of the gold, silver, bronze before I came on, but I actually, if I do say so myself, I quite like it as well. Because it's very like it includes the whole team. I mean, it's like there's there's never a point where everybody in the pharmacy team can't, in whatever setting, and not just community, everybody can contribute something. Um, and to respond to your thoughts about where the future is, I mean, I, I suppose this is a little bit political, but the community pharmacy network is a physical network, and that's quite handy in times of, who would have thought we would have had a pandemic? I know we've talked
Yeah.
the pandemic to death, but it was really handy to be able to distribute tests for COVID through that network, to deliver vaccinations at scale in combination and as part of the wider healthcare team. So that is our core offering. But what you said about technology is really interesting, because I think actually, rather than being a threat to pharmacists, particularly community pharmacists, technology could actually be the savior, because in the case of sepsis, wouldn't it be great if you could just plug in and measure some of those vital signs? I'm assuming you're referring to tools like, like News 2 and that kind of thing. I'm sure you're in that field, there maybe be more up to date resources and so on and so forth. But yeah, the patient walks in, plugs into that consultation, and gets a much better outcome as a result. I just think that's quite interesting. And maybe, again, politically between the professions, there's maybe a little bit of jostling at times, and depends what publications you read. It could be diplomatic here. It could be a bit delicate at times, but I think the demand is such that in the network and the ecosystem, that there's plenty of room for everyone, isn't there, Ron? Um,
I really think there is, and I'm quite wary of offering my opinion on physician associates and similar roles, but suffice to say, I work with a lot of brilliant ones. And look, let's face it, we all know the NHS is really struggling to cope. We've got an aging population. We've got a population who are, well, for the most part, less fit and more comorbid than they used to be. We've got a growing population. We've got huge inequality, particularly for people of non-white ethnicity and people who live in areas of high socioeconomic deprivation. So something's got to change. We have got to improve the delivery of care to our patients. And if that involves ruffling a few feathers among the medical profession, then to my mind, as a very staunch patient advocate, as well as a doctor, so be it. Something has got to change. You're absolutely right, Johnny. This is about News 2 at the moment, and News 2 might not be the perfect panacea for the distant future, but at the moment, it's the best tool we've got to recognize someone who's unwell. And these are basic vital signs. And, many clients who head into a community pharmacy have actually measured a lot of these things themselves at home, particularly in more affluent areas. And I don't see any reason that a community pharmacist who wishes to do so should not measure News 2 and be empowered to act upon their findings in the same way as a paramedic would.
yeah, no, and I agree with you, but I would, I would hopefully show a bit of insight here, and conscious incompetence is never a bad place to be. So
Yeah.
I've often arrived there, and it'd be quite an achievement to get there in my career. There's no shame in saying that. So as we extend these roles, my hope is that, to use your News 2 example, you know, in medical terms, we speak a lot about safety netting the patient, but perhaps the new thing is safety netting the professional as well. My hope is that technology would help to do that so that we allow the professional, whichever one it is, PA, or I've never worked with physician associates, but pharmacists I'm familiar with and their teams, let them progress in a safe way, as safe a way as possible, but narrow down the risks, as you say, the everything's against us in terms of folk getting more well, really, So no, that's really interesting. And then a couple to finish, Ron, really. I mean, so running pharmacy and practice for years now. I guess I've accidentally become a bit of a marketeer. I've sort of, there's no, I don't know if you could tell, but there's definitely no formal training there. But I have picked up sort of marketing principles over the years. And one thing that I want to um, not to embarrass you, but or indulge you too much, but the story of how the Sepsis Trust has has grown in terms of one of the most established patient advocacy organizations in the UK for me is remarkable for some reason, and that's the question. Whatever you've done has absolutely cut through because it's I don't want to speak in business terms, but it is the patient advocacy scene is it's a busy place. But there's something about the Sepsis Trust that cuts through. Can you help me reveal what that is? Because I just find that really interesting how you've been so successful with it.
Well, I mean, that's a really kind observation. So, how have we been so successful at cutting through the noise of public awareness campaigns? I mean, we are a small charity. I think a lot of people think we're a lot bigger than we are. There's only 17 of us. We have a fairly small income compared with the big players in the market, such as the cancer charities, British Heart Foundation, and the like. But I think you're right. We do manage to punch above our weight. We are helped by the fact that sepsis is a really prevalent condition. So our sort of engaged market is much greater in magnitude than, for example, I'm good friends with the chief executive of Meningitis Now, Tom Nutt, and he will sort of say, well, look, we've been so successful that the number of people getting meningitis to come in as new supporters is actually very small now, and we don't have that, well, very successful and wonderful problem. Sepsis still affects hundreds of thousands of people a year around the UK alone, and so we have a significant market of supporters. I think the second thing that we've done as a charity is because we're small, we're quite nimble. We can make decisions really quickly. I always say that I'd be pretty horrified if anyone accessing the charity was more than 2 points of contact away from me or away from Sarah, who runs the charity with me. And I think that ability to deliver personalization is really important. But what we do is we form relationships. Whereas many charities who have marketing budgets will start with, what's it going to cost? We can't say that because we haven't got any money to give. So we form relationships. So we go to large organizations, be they corporate, be they sports clubs, be they voluntary organizations, and we say, can you use your existing dissemination mechanisms to get the message out there to as many people as possible? We don't ask them to invest. We simply ask them to do something that doesn't cost them anything. So the best example I've got of this is the food retailer Iceland Foods, who are a great company to work with. And their finance director was personally affected by sepsis, but being a finance director, of course, he didn't want to spend. So they knew that one of their biggest sellers was milk, and obviously they have to print milk bottle labels anyway. And they just said, well, why don't we just put sepsis messaging on the milk bottle labels? And they did. And we've sold over 1 million of the things. Brilliant. And, it's little ingenious things like that really help to land the message home and make us appear, bigger than we are. It's relationship forming. Another aspect, at the risk of another long answer, is we work a lot with the media. So we've got good relationships with the media. We're generally consulted when there's a press release that even hints at sepsis around. And we obviously proactively reach out. But we work really closely with television programs. And, Coronation Street is probably the best example, without wishing to insult any other television program we've worked with. But, they have run sepsis storylines for several years. They always ask us for input. They usually ask us to review the scripts to make sure that they're not scaremongering, that they're not saying anything wrong. And hey, 8 million people a week watch that program.
Yeah,
So it's another great way of getting the message out there.
absolutely love that. I love that. I feel like I'm just getting you, like, getting started with you to find more out. But the pint of milk thing, or the liter of milk, whatever it is nowadays. um, so my challenge is, what is the community pharmacy pint of milk equivalent? That's interesting, isn't it? And it's to my point
Yeah.
earlier in the conversation about, because if you said to some fancy doctor who's got, professorships, residency somewhere, or something honorary lecture, oh yeah, we just put a bit of text on a milk bottle. I mean, it's not, no offense, Rob, but it's not very intellectually challenging, is it? But the impact of it is absolutely potentially huge, and they're also, so there is evidence that people need to see health promotion information repeatedly as well. So they're buying milk every week or
Yeah.
I just think that is such a clever, yeah, it's really, I didn't know that. That's really
Yeah.
clever. The other thing I was going to say to you was, I know Tom Nutt. I met him recently as well. He's a really nice guy.
Mm-hmm.
He put on an excellent event down in London that I was fortunate to go to. But I hadn't made the link with the vaccine. I know the work of meningitis now will never end, because one thing I learned at that event was the profound long-term effects of that disease. So they'll always have people to support. However, if he does his job right, he should, with buying with the vaccine or whatever, that side of the preventative side of things, he should be quite quiet. Whereas you don't have, not quite. I mean, a vaccine's not quite a silver bullet, but you don't have such a profound intervention with sepsis, and I guess it's going to keep coming and coming, isn't it?
Well, it is, and all of the signals globally are that sepsis is going to continue to increase for the reasons I've mentioned previously. We've got an older, bigger, frailer, more comorbid population than we used to have. And one thing we haven't touched on is the rising threat of antimicrobial resistance, and
Yeah.
we know that there's some areas of the country. So I was speaking to a microbiologist from Leicester recently at the King's Fund, and I sincerely hope they don't mind me sharing this. But what they said was that in areas of low socioeconomic deprivation in Leicester, the rate of resistance of E. coli to first-line antibiotics in people with UTIs is 40%. In areas of highest socioeconomic deprivation, it's 80%. And that's obscene, this inequality in antimicrobial resistance. So I think it's really important that we understand these inequalities, and I think community pharmacy has a huge role to play. They know their local population in delivering their part on this. I think, to the question, what's the community pharmacist's bottle of milk? And I'm thinking completely off the cuff here. So, listeners might want to shoot me down, but what every health professional fears most is sending a child home because we think they're fine and they end up coming to harm. And community pharmacists dispense significant quantities of antipyretic medications, be it ibuprofen, be it paracetamol, in pediatric formulations. And I just wonder whether the community pharmacist bottle of milk is simply to have a set of dispensary bags ready whenever someone comes in with a snotty child seeking some remedy that has safety netting information specifically for children already within the bag or printed on the bag. I think that would be a very emotive thing to do, an effective thing to do, even if it saves one life a year around the country. This is around people coming together to do the right thing. And that would be my immediate idea for a community pharmacy bottle of milk.
Like it, like it. I think you're if I may, you're maybe being a bit pessimistic about the impact of that. I think the impact, there could be serendipitous benefits. I mean, my experience of again being commercial, I used to work for one of the large multiple pharmacies, and a new mum commercially is just it's like you're loyal custom, here we go, so, and they are, that age group, or that cohort of parent and patient will be very engaged in my experience. So they're very receptive to messages that might land. Fair enough, you might save one, two children, and of course that's the right thing to do, but you're also educating mum for future, because there's a lot of childhood. Anybody with kids knows that, as they go through younger childhood and up into teenage years, you're going to have, a tachycardic hot child with 39.5 degree temperature going on there, aren't you? And it's just at that moment in the middle of the night, they might remember that bottle of paracetamol. They might remember the bag. They might just remember one symptom, Ron. So I think that's I wouldn't do down the idea. I think there's more to that actually than what you initially suggested, if I may. Although you're the expert in sepsis, so I'm kind of taking over a bit. Sorry.
No, that's fine, Joe. I think it's the nature, particularly in the days of social media, for anyone in my position to always be a bit conservative, because there's always people wanting to shoot us down. If I say we can save 100 children a year, when in inverted commas only 300 children a year or so die of sepsis, then people will be critical of me. So I will always be a little bit conservative with my public statements, but privately, I know this isn't private, I think you're right. And I think there's just so much more as well. Some listeners will work for some of the larger chains who perhaps manufacture their own equipment. Why not have this messaging on a thermometer that's being sold to that new mum, for example, as well? I think there's so much that we can do.
Yeah. A few years ago, so that particular large multiple they were always trying to get us as a team to increase the commercial transaction value, but I always thought more along the lines of sort of trying to increase the clinical transaction value, really, in the background. And yeah, we're in danger of laboring the point. But to your point, you could, of course, pick the right products and mark them up. So it's lining up the product with the message is quite good marketing. Yeah. Anyway, on that bombshell, one final one, Ron, and it has been, honestly, it's been really interesting speaking to you. I hope we can catch up again and
of course
and work on the bottle of milk. So one final one. So just you've described a lot about the Sepsis Trust, and the success is obvious. It's cut through, but what's your ambition for the organization in the next 5-10 years?
So it's very timely that you should ask that. We're just shaping our strategy for the next 5-10 years, and I think we're conscious as a charity. We have three main work streams, which are clinical advice to health professionals, support for people affected by sepsis, and raising public awareness. And there's so much we need to do in each of those spaces. We have these horizontal activities that underpin everything, which are in essence sort of fundraising. Of course, we can't do anything without money. There's governance, because we need to do things properly. And there's good old-fashioned political lobbying, which has to sort of transcend and be considered in everything we need. So what do we want? I'm going to describe what I want, or what we want, from the healthcare system and the government first, before what we want the charity to become. I think what we need from the government is to really grow up with the way we view infections as a healthcare system. We have, yes, the antimicrobial 5-year strategy. We have, data from entities like ESPOR. We have some not very good measurement of how good we are at treating sepsis. We have much better measurement around the rate of rise of antimicrobial resistance. But we need to join this all together. This is all in the business of preventing harm from infection. So we want to see, just as we see for cancer, for stroke, and so forth, we want to see proper commissioning for excellence in infections management that allows all facets of the healthcare system to be able to invest, to deliver excellence, and to innovate. So that's what we want to happen. For our patients, we'd love to see routine signposting to people who can listen when they've survived sepsis or been bereaved by sepsis, and, maybe even, just as exists for other conditions, some degree of resource rehabilitation. Now, how's the charity going to deliver that? Now, obviously, we are reasonably expert in working with the media and working with the government and political lobbying, so we'll continue that activity. We have to become, over the next 5 to 10 years, the best run healthcare charity in the country. We have to transition to the digital space for all of our awareness and education resources, whilst retaining the traditional resources we have for those who are less digitally literate. We need to segment our service users as a charity so that we deliver much better representation to underrepresented areas of the community. And I was talking to our chairman of trustees the other day, and I said, I have no doubt, and he agreed, I have no doubt that we should be investing much more per capita in public awareness for people from minority ethnic groups and people in areas of highest socioeconomic deprivation, and those people on the fringes of society, such as and including the homeless, than we do on, well-educated, middle-class Caucasian populations. At the moment, we're completely failing to do that. And we need to become, as an organization, much more data-driven to move closer to the research environment, but to build huge intelligence around what's happening to our public when they develop infections, how they're being treated by the healthcare system, and what their outcomes are afterwards. And then we can start to learn what makes a difference. So those are my personal ambitions for the coming years. These, of course, need to be ratified by our trustees. I don't want to get into trouble, but I think this is the sort of direction we're going to be traveling in.
Do you think, right, I know I said it was my last one. This is really my last one, and then I'll shut up. I see a parallel between antimicrobial resistance and COVID to an extent. And it not in any way, shape, or form the nature of the disease or anything like that, but more how the population reacts to it. I think in the early days of COVID or the pandemic, when it set in, I'm thinking March, April, before things really kicked off, there was a huge amount of optimism bias. So by that, I mean, of course, like, I think the general population thought, this is too serious, this can't be happening, this can't be happening, everything's going to be okay, it's going to be fine. Boom, it wasn't.
Yeah.
And then we were fortunate to get the vaccine and so on and so forth. Yeah. Obviously, from what you're saying, you feel the same as the case for antimicrobial resistance, do you? And if you do, because I've sent away urine samples for UTIs myself. I don't, I know you were at the King's Fund, but I don't need to go to read the academic stuff to see that, the results come back resistant to trimethoprim, resistant to nitrofurantoin. Oh, right, we'll have to go to fosamaxin. Right, fair enough. Yeah. So how does the rubber hit the road? Is it going to be sudden, or will it be a gradual sort of death spiral?
Well, yeah, I think so. The first thing to say in response to that, I think, is that, Dame Sally Davies has done more than any other human being on the planet to raise policy awareness around antimicrobial resistance. And I think, in the future, probably millions of humans will have her to thank for their lives. But you're quite right. The public message hasn't really stuck in the same way as the policy message has stuck. And I think the reason behind that is that people have heard about a perceived future threat. Dame Sally's talked about, we might not be able to safely do a hip replacement in 50 years' time. And, that doesn't get our children very interested, because that's quite literally a lifetime away for them. I think what our public need is to actually hear the real message that you've described, that AMR is here now. It is harming people in their thousands in our hospitals today, not next year, not in 50 years' time, right now. There are people in many areas of the country who are given antibiotics for a UTI that have no chance of working because the
Yeah.
organisms are already resistant, and that will be at the very best inconvenient for those people. So I think we need to make the message immediate and personal. I think now, again, this is a personal prejudice. This is not the view of the UK Sepsis Trust necessarily. But I think we need to concede that people don't really die of antimicrobial resistance. They die of infections we can't treat because of antimicrobial resistance. They die of sepsis, essentially, is
Mhm.
the mode of death for people for whom the mechanism of death is antimicrobial resistance. And I think we need to bring the messages a little bit closer together. And then the final thing I think we need to say to our public is that is actually action you can take right now to play your part in addressing this existential crisis, just as we do with climate change and recycling and plastics in the ocean and all of those things. I mean, hey, it wasn't too hard to sell people into electric vehicles, was it? But, because people want to feel that they're doing something. So
Mhm.
we need to persuade them that antimicrobial resistance, in Dame Sally's own words, is a more immediate threat to human life than climate change, and actually then tell them what they can do about it. Have a responsible approach to seeking antibiotic therapy and expectations around it. Complete the course, dispose of any unused antibiotics safely so that they don't contaminate the environment. And hey, dare we say this? Begin to consume meat a lot more responsibly, because
Mm.
the vast majority of antimicrobials used even in this country, let alone worldwide, are in animal health. And although this country has done brilliant work in banning the use of antibiotics as growth promoters, this still goes on routinely in North America, Poland, and many other countries. But what we haven't banned is the injudicious use of antibiotics to treat a whole herd of animals. So I think one simple step is that we educate society to just move back a bit, move back a few decades to when meat was a luxury for 1 or 2 days a year. Buy smaller volumes of higher quality meat at the same cost to ourselves. The government need to work to ensure that those on lower incomes have access to high quality protein if they are avoiding meat. But I think these are simple steps that people can take to slow things down a little. We're not going to stop it, but we can slow it.
It's really interesting, Ron. You're just, I'm sorry for going on. I promise I will be quiet in a minute. But yeah, I think what you're describing. I mean, I don't want to oversimplify because you went on a few strands there, which is really interesting. But at the risk of oversimplifying the antimicrobial resistance piece, it is a little bit. We in community pharmacy, we've got a similar problem in terms of why the government don't invest enough right now, and it's because basic human psychology is I'm gonna act to do something that benefits myself
Yeah.
or helps me avoid jeopardy. And organizations are the same. Unfortunately, in my career, professional, personal, and business, it is so fascinating how often it comes down to those two pieces. You used the example, a hip replacement in 50 years' time to give me an extra 5 years walking, and obviously all the myriad serendipitous health benefits that comes with that. I'm not bothered about that when I'm 30.
Yeah.
So whoever could crack that, it almost needs a rebrand. Needs you to work on it, Ron. The antimicrobial resistance needs a rebrand. Resistant, and even the word, isn't it? Resistance. It's
Yeah.
sort of it implies that we're resisting. There's implications there that don't match the severity of the whole thing. But anyway, I honestly must shut up because it's been Dr. Ron Daniels. It's been absolutely brilliant speaking to you. I mean, I knew it was going to be good, but very, very insightful conversation. I know you're extremely busy, so I really appreciate your time, and I really hope we can catch up again when we've more time, hopefully in a cafe or a bar sometime over a nice glass or a cup of something, and yeah, we can chat again. But in the meantime, thank you so much.
Well, that sounds absolutely lovely. I will hold you to that. And thank you for spreading the message in this brilliant way.